would like to give you some results, small talk about probably the most encouraging nowadays implementation of immune checkpoint inhibitors into the treatment of non-small cell lung cancer. We know that this is probably the deadliest tumor, with about more than 2 million people diagnosed in 2020, and more than about almost 2 million deaths the same year, 2020. So I will show you the results of adjuvant treatment. This is the first immune checkpoint inhibitor which is registered for the treatment of early non-small cell lung cancer. And despite the surgery and despite the chemotherapy, which was the gold standard for the treatment of early non-small cell lung cancer, most of the patients in stage 2 and stage 3 will relapse, or they will have recurrence in the first 5 years. For stage 2, there are more than 60%, and for stage 3, more than 75% will experience recurrence in the first 5 years. So we do have a big gap to fill, and I think that atezolizumab is the first one to fill that gap, and I'll show the results. We know quite well that we do have upfront surgery. After that, we do have chemotherapy, and nowadays, after chemotherapy, we'll have immune checkpoint inhibitors. I do not think that that's right. It's quite interesting. So let me start with the clinical data about Tecentriq in the adjuvant setting. Tecentriq is registered as immunotherapy as adjuvant treatment of following complete resection and chemotherapy for adult patients with non-small cell lung cancer with a high risk of recurrence and PD-L1 expression 50 or more than 50% on the tumor cells, and who are not EGFR or ALK mutant. The trial that gives us the data is IMpower010, and it's an open label phase 3 trial of atezolizumab after surgery and chemotherapy in patients in stages 1B to 3A, and this is based on the 7th edition of AJCC staging system. And first of all, we do have patients that were enrolled with completely resected stage 1B to 3A non-small cell lung cancer, stage 1B tumors more than 4 centimeters. We all know that it was in chemotherapy, or it is in chemotherapy. We do give chemotherapy to high-risk patients, which tumors are more than 4 centimeters. ECOG performance status 0 to 1, with lobectomy, with surgery performed, and there should be tumor tissue for PD-L1 analysis. After surgery, they were first given cisplatin doublet, and after the 1 to 4 cycles, they were given atezolizumab up for 1 year. And this is the active arm, and the control arm is best supportive care, which is was a standard of treatment by now. Stratification factors, sex, of course, stages, histology, and PD-L1 expression on tumor and immune cells. Primary endpoints, there is hierarchical, they were tested hierarchically and were reported by the investigators. And first of all, there were tested PD-L1 patients with PD-L1 expression 1 or more than 1%, measured with antibody SP263 in stage 2 to 3A, and if positive result, all randomized patients from stage 2 to stage 3A were tested, and after that were tested if positive results from the second group were tested. The intent to treat population stage 1B to 3A for disease-free survival, and disease-free survival is defined as tumor relapse, new primary non-small cell lung cancer, or death of any cause. Key secondary points were overall survival, disease-free survival in overexpressed tumors, PDL 50 or more than 50% of tumor cells in stage 2 to 3A population, and 3-year and 5-year disease-free survival. This is the hierarchical testing, as I told, the disease-free survival was tested firstly PD-L1 on tumor cells 1 or more than 1% in stage 2 to 3A, and the data, this was done because we know that from the metastatic setting in the usage of immune checkpoint inhibitors, that we know that the results correlate between the expression of the results from immune therapy correlate with the expression of PD-L1 on tumor cells or immune cells. And after that, if positive, the disease-free survival was tested in all randomized patients from stages 2 to 3A. And if then positive, the disease-free survival in the intent to treat population. These were the primary endpoints of the trials. And the key secondary endpoint was the overall survival in the intent to treat population. And also the other key secondary point was the disease-free survival in the overexpressed tumors, 50 and more than 50% of PDL. The disease-free survival, you can see that after more than 32 months of follow-up, median follow-up of 32 months, the median disease-free survival in the group of patients that were treated with atezolizumab was not reached, while in those who were treated with best supportive care was 35.3 months, which shows that on the third year, 60% from the active arm from the patients who were treated with atezolizumab were without any recurrence, new primary tumor, and or death. While in the control arm of the best supportive care, it was about 46%. In the all subgroups, there were consistent results. Almost all of the subgroups, let's say all of the subgroups, benefited from the treatment with atezolizumab, in contrast with those with best supportive care. And we are talking about still about patients with PD-L1 expression on tumor cells 1 or more than 1% in stages 2 to 3A. As I told, hierarchically testing means that when the first group shows positive results, the second group that were tested was for the disease-free survival in all randomized patients from the stage 2 to 3A. It's another primary endpoint, and the results showed us that the median disease-free survival in the active arm when treated with atezolizumab, when give atezolizumab to the patient, was 42.3 months, while in the control arm with for the patients who were treated with best supportive care was 35.3 months. That means that we do have a 21% risk of reduction from recurrence, relapse, or death in all randomized patients in stage 2 to 3A. And the disease-free survival improvement with atezolizumab versus best supportive care was proportional. Of course, we know that from the metastatic setting, as I said, from the PD-L1 expression levels. The best results are seen when the tumor overexpresses PD-L1 50 or more than 50%. The third, let's say, hierarchically testing group was the intent to treat population of the patients who were written informed consent. The disease-free survival, the median disease-free survival for those patients after follow-up, median follow-up of 32 months, was not reached in the group of the patients that were treated with atezolizumab, while it was 37.2 months in the group of patients that were treated with best supportive care. And one of the key secondary endpoints was the results for adjuvant atezolizumab in the high expressors with PDL 50 or more than 50% in the stages 2 to 3. This is a subgroup. The baseline characteristics in this subgroup were well balanced by the sex, by the race, by the smoke history, by the lymph node, mediastinal lymph node involvement. They were well balanced. So the results showed that the median disease-free survival, was improved in the PD-L1 high group of patients in the stages 2 to 3A, and this subgroup was divided into two other subgroups. They are EGFR or ALK mutant, let's say, tumors, and EGFR and ALK wild type tumors. And in both of those subgroups, the results are in favor of using atezolizumab in an adjuvant setting from stages 2 to 3A in PD-L1 expressors. And they both show about 57% reduction of the risk of disease progression, relapse, or death in those patients, despite having or EGFR or ALK mutations or not. And the disease-free survival analysis was also conducted in the key PD-L1 high subgroups, excluding EGFR ALK mutant tumors, according to the age, according to the ECOG performance status, tobacco use history, and of course, according to the mediastinal lymph node involvement. And in all of those subgroups, the results were in favor of giving atezolizumab in those subgroup of patients with high PD-L1 expressors. Then the results were better than the results from the best supportive care given after surgery and chemotherapy. Overall survival was secondary endpoint, and the overall survival of high expressors and stage 2 and 3A showed some trend to improvement of the 5-year overall survival in the high expressors of those stages. The median of overall survival was not reached in both groups, but still there is a trend of improving the overall survival while give those patients atezolizumab as an adjuvant setting. The highest benefit, of course, in the meaning of overall survival was observed in those patients who were, let's say, high expressors, in those who have expression levels of PD-L1 50 or more than 50%, and there is a trend to a little bit worse results, while in the subgroup of patients with PD-L1 low, less than 1% expression. And on the 5th year, in all those high expressors who are EGFR or ALK wild type, in those groups, more than 80% of patients were alive at the 5th year, while about 67 in the control arm of patients who were given best supportive care. What about safety? We do have a lot of practice with atezolizumab, and it's well tolerated. The adverse events are in most of the times manageable and could be controlled. And as you can see, they were not grade 5 adverse event, immune or chemo related. About 30% of the patient, they discontinued, less than 30%, about 20% of patients discontinued treatment due to immune-related adverse events. There were a lot less, well, best supportive care, of course. And this profile, toxicity profile, proves that atezolizumab is, let's say, well tolerated and with, let's say, manageable toxicities. And the key warning points: Tecentriq is the first immune therapy that is approved for adjuvant setting in high-risk patients for surgery and chemotherapy for non-small cell lung cancer. And IMpower010 meets a primary endpoint, that is the median of disease-free survival in the patients with PD-L1 1 or more than 1%, stages 2 to 3 non-small cell lung cancer. The disease-free survival correlates with the levels of expression of PD-L1 on the tumor cells, of course, and clinical benefit of Tecentriq benefit was consistently observed in clinically relevant subgroups according to the PD-L1 % or more than 1% from stages 2 to 3A, and the safety profile of adjuvant Tecentriq is acceptable and consistent with the established fraud Tecentriq monotherapy across multiple indication lines. Thank you.